possible, either off screen to allow the speakers to be visible to as many people as we can. We're hopeful that the IT can cope with the level of volume of people we've got attending today. We've had in excess of 200 people register. That is no mean feat for a virtual event, but it shows the wealth of encouragement that people are going to enjoy. And we hope that today really helps to clarify the ambition of the Academy, demonstrate how we're going to do it, and to really shape and inspire our partners across both BHR and NEL and wider. We have quite a national representation from ICS organisations today to help us really shape and understand how workforce transformation can be achieved. So just bear with me, I will be facilitating the session today. So I will try and manage all of the elements of driving the bus, but Joe is at the steering wheel. So we are delighted here today collectively to showcase a very full agenda, which you have all seen. We have extensive presentations. I will do my level best to ensure that actually the presentation speakers get all of their slides through. I will have to performance manage that slightly, but bear with me. What we would ask of the audience, because we really do value your feedback, is to contribute in the comments section, but this is an event, not a meeting, so we would ask you to refrain from using the hand icons. So if you wouldn't mind, no hand icons, but lots of commentary, which we will collect and use as an evaluation to help really understand where you felt the added value on today's content was, what you'd like more of, how you'd like to see that shaped, and really to test the water out in terms of our innovative approach to workforce planning. So underpinning the development of improving health and wellbeing outcomes for our local people, we have to get our infrastructure correct. And we are hoping today that our live demonstration of our first ICS in the country to have broken ground on developing an ICS data management dashboard. We have a live demonstration today provided by our suppliers Attain, and very much look forward to your feedback in terms of how we shape that. So without further ado, I'm going to welcome Joe Fielder, Chairman of NELFT and today's Chair of the Academy in terms of sponsor, and ask for his contribution in terms of what today represents and how the journey started. So Joe, over to you.
Thank you very much indeed, Ali. I hope everyone can hear me clearly. A really good afternoon to everyone and a very warm welcome to you all. As Ali said, I'm Joe Fielder, I'm Chair of NELFT, and I wanted to thank you all for giving your time this afternoon to this exciting launch event for what is a vital project for Barking, Havering, Redbridge and North East London. It's a privilege to be asked to open our proceedings this afternoon, and also the beginnings of a realisation of a vision that I and other colleagues in NELFT, BHR, our local authorities and commissioners shared as far back as 2014. So what was that vision about, and why did we have this vision of an academy, and what was its purpose? Young people in our communities need gainful, lasting employment, and so we were thinking about work programs that combine with skills development to achieve fulfilling and sustainable careers. That can be true as well of maturer people in our communities who aspire to better things and to do and contribute more. So we believe we can create those careers through new options and new alternatives through our academy. The NHS nationally and for us locally has some significant gaps in our workforce. We too often have to make do with short-term agency and locum support to fill vital gaps. Whilst we are grateful for that support, we know that the high cost of agency working make current levels unsustainable. And there is much evidence that tells us that a stable and permanent workforce delivers better care and improved health outcomes. We believe our residents and communities deserve the very best care we can provide. So some years ago now, the concept of growing our own was
Oh, Joe, we've lost the sound. Ben.
Years ago.
Thank you, we've got it back, thank you.
Yeah, some years ago, the concept of growing our own was born, and our vision was to align this growing workforce demand with the creation of real opportunities, particularly for our young people in BHR, Barking, Havering and Redbridge. We envisage they will both serve and prosper through fulfilling careers and filling workforce gaps in health and social care provision. We have invested with Health Education England, local system partners and commissioners to derive a data-led academy that will facilitate and broker the matching of workforce needs and demands to those career aspirations and needs in our young people and communities. This data-led approach will give a vital view of the short, medium and long-term workforce needs, such that evolving needs can be anticipated, planned for and then delivered to improve outcomes and population health, while simultaneously reducing inequalities. We have the support of national bodies, our regulators, such as NHS England, Health Education England, as well as our local authority colleagues in Barking, Havering, Redbridge, and beyond in the North East London system. We have multiple providers and our excellent academic institutions ready to support us and help create something very special and very powerful. So I ask you in my introduction then, all of you, to get behind our academy, and I commend all of you to our contributors this afternoon for all of their efforts so far in bringing us to this exciting launch event. Let's create opportunities for our citizens. Let's enable them to fill our vital workforce gaps, and let's empower our communities and those that serve them to deliver the very best healthcare and social care in London and indeed nationally. Thank you, and back to you, Ali.
Thank you, Joe. And as our audience grows, apologies for the slight break in the sound there. I think that was just lots and lots of people joining at the same time. So we'll move through to a strategic context provided by Lizzie Smith, who actually was one of our key supporters from HEE, which actually allowed the Academy to formally launch and invest in its strategic development. So thank you, Lizzie. We are delighted here for you to offer your perspective on workforce priorities from a London level, and look forward to the contribution you offer today. Lizzie.
Many thanks. Thank you so much for inviting me. So as has been said, I'm Lizzie Smith. I'm the Regional Director for Health Education England for the London region, and I'm absolutely thrilled to be here today to join this and to give our support to this fantastic initiative. We're really pleased to have been able to support the development of the Academy, and we really want to carry on working in partnership and working alongside the Academy to learn what we can and to see how we might be able to continue to support this kind of approach, which we really strongly believe in as part of the future of how we work to support the workforce in health and care. I'm going to just if I just could click onto the next slide. I'm going to only just talk for a very few minutes, because I know you've got lots and lots on the agenda today, and I'm not going to be one of those people that starts to let an agenda slip behind. But I thought it might just be helpful. Some people, I'm sure, won't be too familiar with HEE and what we do. So I was going to say a very little bit about that. I'll just touch on some of the priorities that we've got through the London Workforce Board and the People Board rather, and a couple of things that we're thinking about how we're going to change how we operate so that we can really fit around integrated care systems and this future model of service planning and delivery across these different places around London and around the country, and then just a little bit about how we'll support people. But I'm really going to canter through. So if we could go to the next slide. So for people who aren't familiar with HE, we're one of the arm's length bodies to the Department of Health. We were established in 2012 around one of the previous reorganisations of the NHS. And our purpose, as it says on the slide, is to support the delivery of excellent healthcare and health improvement to the patients and public of England by ensuring that the workforce of today and tomorrow has the right numbers, skills, values and behaviours at the right time in the right place. So just a small challenge to us there. We have a responsibility around workforce supply, workforce planning and intelligence, and we work collaboratively with partners around things like workforce transformation. And a great example of that is the Academy being launched today. You know, that kind of initiative that actually brings to life, you know, how you support people and develop people and bring people into the workforce across, you know, different parts of the system is something that we're really interested in. And we also do a lot of work in education and education commissioning and some delivery as well. So we're all about people, education, planning and workforce. That's us in HEE. So if I go on to the next slide. This slide is about the London People Board. The London People Board was established in June 2020 or thereabouts. And although we were already planning on establishing a People Board before the COVID pandemic took a grip, the COVID pandemic actually accelerated it because the pace of work for around workforce, around the pandemic was so fast. And I know I'm here with people today who will have lived and experienced that, you know, don't need to be told. But then, of course, the challenge of workforce recovery and education and sort of supply recovery was so great that we actually accelerated the development of the People Board and got it into place quite quickly. And you'll see there in the 4 pink boxes that the London People Board has identified those 4 priorities for the next sort of 12 to 18 months. And those aspirations about how it will work. And there's a picture there of the NHS People Plan. So the People Board has a remit in relation to how the People Plan is implemented across London as well, although that's not by any means its sole remit. It's chaired independently. It brings together many different people from the system, lots of integrated care system representatives, provider representatives, and other people too, like the GLA and other bodies. It's a very vibrant, very dynamic board, and those 4 priority areas each have subcommittees, which I'm sure many people on the meeting today may be involved with. If I just skip on to the next slide. This slide aims to show the journey we're on in HEE to think about how we need to change and how we need to work in a different way to be able to provide the support to the integrated care systems as they come into place. And you'll see it's like an upside down pyramid with a sort of national driver being at the bottom, and the predominant sort of driving force being the integrated care system at the top, and the regions, like the region that I lead across London, so sat there in the middle, being the conduit between those, because clearly there are government mandates and targets and stuff that in HE we are tasked to deliver. So that could be around, for example, increasing the number of GPs, establishing the nursing associate role. There are many examples, training hubs, and so on. But equally, what we need to see is the integrated care systems and the places themselves and the communities within the integrated care systems driving our agenda and driving how we use our resources and how you can access, you know, our resources, our skills, our expertise, our, you know, the tools and things that we have to enable you to improve the health and care of the population that you serve. And so we've been spending a huge amount of time in HEE really working through that and trying to describe, you know, the way in which we will change in order to be able to do that. If I skip on to the next slide, actually I'm going to skip that one altogether. If we could go on to the one after that, thank you. So this slide is some work that's been done within the London team to think particularly about what our offer into systems will be from HEE, and how we'll do things like partner up with systems to develop things like this academy, how we will help systems to create strategies around workforce supply gaps that you may have. So on the back of COVID, we know how pressurised the workforce is, and that in order to do the recovery that we need to do, and also to manage the ongoing demands of the pandemic, we can't just carry on working the same way we always have, with our staff working the same way they always have. You know, we need to find new innovative ways of doing things, both to take the pressure off people individually, but also in order to be able to deliver such a broad range of services through such a challenging time. So we have got lots of different teams and resources within HEE, but you can see here it's been broken down into a few categories that hopefully just make it a little bit clearer, the kind of thing that we do. So the stuff around diagnostics and being able to work with systems and providers and provider collaboratives or individual, you know, hospitals or whoever it might be, to help sort of determine what's the problem here, you know, where are the pressures. If you're looking at a care pathway around, for example, diagnostics or ophthalmology, you know, where are the blockers in that in terms of your workforce? How can we help people to think differently? How might education programs need to change? What new roles might you need that would help you to work in a different way? That's kind of what we're talking about. We have a big role in planning and intelligence, which probably many people will kind of know us for, and we need to really build on that as we work with integrated care systems and help integrated care system workforce functions build their capacity and capability in that area, and use the tools and the resources that we have in order to do that. And you can also see we're talking about building capacity and capability. You know, we also have a big role in quality. You know, the quality of the education we commission and provide, the quality of the experience that learners have, and how that impacts on the experience that patients have when they're using services. Because of course, none of these things are distinct from each other. They're all very much aligned to each other, and the way that we'll do that in HEE is through strengthening our kind of account management model, so that, you know, systems and ICSs will know the teams that they've got available to them in HEE to be able to be there. But I hope, given the nature of what we're doing this afternoon, that you already see that that's our way of working, and that you already feel that you've got that access into people into HEE. And like I say, this afternoon and what you're doing today, it's just such a beautiful example of how that partnership and collaboration can come together. That's my last slide. So I'm not going to say any more. I haven't seen any comments or anything like that. But if people are interested to hear any more about HEE, or would like to speak about any of the work that we're doing to prepare ourselves and to get ready, you know, to support new systems and any of the ongoing work that we do in any of those areas, I'm always really happy to hear from people, and there are other people from HEE I know in the audience today who would equally be really happy to have those conversations and to build those networks with you. So thanks very much again for inviting me, and congratulations on the Academy and all the work that you're doing.
Thank you, Lizzie. Very exciting times. Come with the same challenges, definitely. Workforce transformation is a beast in itself, but I think actually the workforce of the future depends on the collaborative partnership across systems, and you've certainly highlighted that. So thank you for joining us. We're going to move on now to a little bit more detail in terms of the BHR Academy's offer. And I'd like to hand over and welcome Catherine Halford, who is our Chief Nurse at BHR UT and also our sponsor for the Academy. Catherine.
Thank you very much, and good afternoon. I'm absolutely delighted to be here this afternoon, because the idea of having an academy has really been a part of my vision for our health and care environment for about 4 or 5 years. So normally when I think that we need to develop a project, do something new, be innovative, it happens quite quickly. But for me, this has taken quite a long time. But I think the fact that we're here today with such good data, good information, gives us a really strong platform to work forward with in the future. We know that we have a real workforce challenge now, and we're likely to have that workforce challenge going forward. So we do need to address it. And we need to make sure that our local workforce can work in our local environment. So they can work in our hospital, they can work in primary care, they can work in our social care providers. So where does that workforce get its skills from? And I think we are the people that need to provide those skills. We are the people who need to train people and give people the opportunity. Now, lots of us do that all the time. So I work at BHR UK, we train hundreds of nurses, we train lots of doctors, we train all sorts of people, but we don't really share that training across the whole sector. So I think what the Academy enables us to do is to look at what the workforce looks like for the future and how we as a health economy can look at training and providing that workforce going forward. So how do we do that? Well, I think we need to look at our local population and we need to say, do they have the right skill sets? Do they want to work in this environment? And actually, I think we need to market health and social care a lot more, because people think if you work in a hospital, you're a nurse or you're a doctor, or you have to do something with sort of blood and gore, really. But actually, many of you that I can see on the screen today do work in this sort of environment and probably have never been near a patient in terms of having to provide personal care. But how do we market those opportunities to people? Where is the next Henry Black coming from? Where do we get that experience from? How do we say to people, you can come in as an apprentice and end up as our next Director of Finance or Director of IM&T or Workforce Director? Because I don't think those opportunities are really showcased within our local schools, our local job centres. People often come in from university, and I think people often think you have to have a degree before you join us, but that's absolutely not the case. And I think what's happened over the last few years is that we have had significantly increased opportunities with the apprenticeship schemes. So people who perhaps have not got formal qualifications are able to join us, work, develop, grow into the workforce of the future. And I'd just like to take a couple of minutes to talk about some of the programmes that I've personally been running since I joined the organisation some 5.5 years ago. I have a number of healthcare assistants who, when I joined the Trust, had worked in the Trust for 15, 20, 25 years. So these are individuals who work alongside the registered nurses, help providing care to the patients on a daily basis, help with basic needs, washing, feeding, etc. And they've never really had any opportunity to develop. So we really embraced the Nurse Associate programme and had 120 nurse associates, many of whom we'd shared actually with NELF. Those nurse associates undertook a 2-year programme, so these are people without formal qualifications or particularly any experience in writing academic essays. They were supported and actually all of them completed that programme. So they're now able to work at a band 4 level. So for us in healthcare, that's just below a professional registration level. So that's really good. But it's also given a lot of people, so some 80 of that 120, are now on courses to become registered nurses. So I've got about 12 of those have now qualified, the rest are coming through the pipeline. But it just shows that in 5.5 years, we've gone from having people with no qualifications, probably no belief that they would ever be able to be a qualified nurse, now being a qualified nurse. And they will stay with us for the rest of their career, probably. They will become the ward sisters of the future, the matrons of the future. But if we hadn't had this opportunity in terms of apprenticeships, if we hadn't supported people financially to complete their training, they would still be healthcare assistants. So I think what the Academy does is starts to grow on schemes on the basis of these schemes. So that's been successful for nursing. So we're now doing it for allied health professionals. We're looking at physios, OTs, and just starting to look at midwives as well. But those, of course, are all clinical positions. So we're also starting to extend that, and we've got our first apprentices now going into the estates department. We have them in our HR department. We have them in our education and training department, and they will become our future leaders. But they are people who have absolutely lived here, grown up in this environment, and are working in the environment now, so giving back to their community. But actually, only a small number of people are able to access those programs, and that's for a number of reasons. So sometimes people don't think they can do it, they don't think they're allowed to do it, they don't know how to apply. So how do we support people who perhaps traditionally haven't worked within this type of sector to actually become part of our family, to actually grow and develop? And I think this is our next stage of work. And one of the things that we did last summer was we offered the opportunity to 12 vulnerable children and young people to come and join us over the summer holidays. They spent 2 days a week with us, and as a result of that, 4 of them are now starting their apprenticeships this September with us. Those individuals didn't believe that they could work in a hospital. They didn't think there would be an opportunity for them to be in a hospital, but we were able to demonstrate their work, they can. We've grown this work now, so we're going to have 36 this year, and we're supported by DWP and also West Ham, who are very interested in supporting this type of programme. But that's only 36 people. How do we grow that across the patch? So we're doing it at BHR, but actually what the Academy will give us the opportunity to do is to grow that in NELF, to grow it in social care, to grow it in primary care, because those opportunities will be there as well. But we need to have the infrastructure and support for those people coming in. And I think that that's what the Academy gives us. The Academy, for me, is a sort of hub, a repository of information. We have lots of people who are doing really great training across our patch. But actually, it's rather difficult to find out that information. It's really hard to go to one place to say, I'd like to work in the hospital, what are the jobs that I can do? You can, of course, look on the jobs website and find if there's a job, so you can do that. But where's those education packages? Where's that professional development, and what does that look like? So I think what the hub will give us, the Academy, will give us is a hub where we can see that as a repository, but we will work with system partners to ensure that the opportunities are available for all. But this isn't only about children and young people. This is about people at any time in their life making a change, deciding they want to have a different role. And we should be able to support people to come in and educate people so they know how to come into the organisations, how to work within health and social care. We know that people move across health and social care, and we know that often people migrate towards the sort of larger hospitals and don't necessarily want to work in the nursing homes. So what we need to do, I think, is to develop systems which enable people to rotate through those organisations. So you might spend some time working in the hospital, some time working in primary care, some time working in social care, so that wherever patients are in our systems, they will get an equally good service. They will have equally well-trained people to look after them. But we can do that much more easily if we work in partnership and in a formal partnership, which is what I think this Academy gives us. So I think this is a really exciting time for our boroughs. We have lots of unemployment at the moment in our boroughs, and an opportunity to really galvanise people into the opportunity and share the opportunities that are available to them. But more than that, I think it gives our young people, our people who have been furloughed, lost their jobs, an opportunity to really think about what sort of jobs are available to them. What transferable skills have they got, and how can they come and join us as part of the workforce of the future? So I hope that in 5 or 10 years' time, that as people are looking for new jobs, they really look to the Academy to give them the sorts of opportunities, to be the place that people go to really think about what sort of job can I do? How can I help? How can I get a really good job with positive employment prospects and an opportunity to grow and develop over my working career? So thank you very much indeed. I hope that gives you a brief insight into where I think we should be, where we should be going. And I'm actually very excited about what the next year to 18 months brings, and how this really develops and how we really start to meet the needs of our growing population and ensure that our patient experience stays very positive. Thank you very much indeed.
Thank you, Catherine, and a really important message as the bedrock for our boroughs in Barking, Havering and Redbridge. It's my pleasure now to hand over to part of the how we are going to change some of the infrastructure and make this a much more data-led approach. Strengthening workforce planning capabilities has been a real ambition, and over the last 6 months we have worked very, very hard to review how as a system we could be more targeted at strengthening our recruitment and retention. So I'm going to hand over now to Simon Hart, who's the HRD at Nelft, and ask him to set the scene and describe the tool that actually BHR has actually crafted it in response to that through the Academy. Our team of suppliers will be led by Martin Wilson as the Executive Chair in Attain, and we have Gail Clark, who's going to give a demonstration in terms of the added value to support social care. So it's a very rounded approach. So Simon, over to you.
Thank you, Ali. So as Ali says, my name's Simon Hart. I'm the Director of People and Culture at Nelft. And this has been a really interesting approach that we've been able to take within BHR. So if we could perhaps have my slide, please. So Plato, of course, says, know thyself. And that's, of course, where we need to start before we can do any of the work at the scale that we need to across the academy that Catherine has just been describing, that has been done within BHRUT. So this is the baseline for the opportunities that we can see out there. So actually, our genuinely understanding what our total workforce is therefore the critical enabler to have a functional BHR academy. It is from this that everything starts. But the work that's been done over the summer, over the last few months with our Attain colleagues and with everybody within the BHR space has been to build a really innovative approach to the collection and interpretation of workforce information. And you'll see that when Martin takes you through the data. But we've all worked in places where we've just been feeding the beast with data. But what this, I think, does is give a complete, and I think for the first time, possibly anywhere, a complete granular picture of the health and social care workforce in BHR that covers hospital, it covers community, it covers primary, and it covers social care. So it is a total picture of our workforce. And from that total picture, we can then understand what are our needs, genuine needs, from a clear evidence base. And once we're doing that, then we are knowing that every piece of work that we do through the academy will be genuinely adding value, and we can evidence that is the case. So it is the absolute driver for everything that we are proposing to do. So as I say, it allows us to identify current and future workforce challenges. It allows us to target interventions, and it allows us to identify issues around supply, recruitment, retention, education, and indeed equality and diversity as well. One of the key issues with this, and why it is we've taken the time to do it rather than just sending around lots of data collection forms, has been because of the importance of data, not just the data itself, but how we collect the data and how we look after the data. So everything that we spent a lot of time, and there have been some excellent support from our colleagues to make sure that we've got a fully GDPR data protection compliant process that is both for the current collection of data, but also for going forwards. The staff and colleagues can be confident that not only are we going to use the data well, we are going to be keeping the data well as well. And I think that's important for the trust that needs to go into building this process too. So the platform itself, you'll see the details shortly, but I think it's the keystone for everything that we're going to do. And with that, I think I probably ought to shut up and let you actually see the real quality of what's out there, which is what Martin is going to show you now.
Thank you. So we're just going to invite Gail to contribute just where this also fits in terms of the aspects of linking this to social care. So Gail, tell us about the RES.
Okay, thank you very much. I'm really delighted to be here today and just tell you about some of the, how this links in really nicely with another piece of work that we're doing. And it's all about connections and alignment, really. And I think that's what the Academy allows us to do, and the richness of the data management dashboard tool as well. So Barking Dagenham has been selected as one of 18 local authorities across England as a pilot site for the social care workforce race equality standard. So a standard that's been adopted in the NHS as a tool providing an evidence-based approach to monitor progress against several indicators of workforce equality, race equality. Some colleagues at the launch today across BHR and from other areas will be familiar with this work and approach. But it's a data-informed methodology, as you can see, centred around the 9 RES core metrics here on this slide. But the important part, and why I've been asked to say a few words, is that this fits in very nicely with the data management dashboard and the opportunities it brings to enhance our work and significantly add to the availability of quality, accessible data sets on our workforce. So the dashboard and the RES pilot gives us an opportunity to explore and monitor progress around workforce equality, particularly pay, recruitment, progression and turnover. Secondly, a critical part of the RES methodology, which you can see from the diagram, is action planning, and more importantly, informed by the views of our workforce, shaping the conversation, reviewing the data, bringing perspectives, lived experience and practitioner insight, helping us to explore what's worked and what's not. So the intention of the social care workforce RES is to identify opportunities to roll out this methodology further, including across our whole workforce, but also across a wider system. So the opportunity that we have through the BHR Health and Care Academy is to do just that across the partnership, underpinned by high quality data management dashboard and a sophisticated view of our workforce. So we are at the very start of the rollout of the RES in LBBD, but the intention is to share our learning through the Academy to keep, for example, barriers to progression, recruitment training and other workforce challenges in the centre of what we're doing to create meaningful change. So I'd like to now hand you over to the demonstration. Thank you.
Thank you, Gail. Martin, over to you.
Thank you very much. I'm Martin Wilson, one of the directors at Attain. I'll very shortly hand over to my colleague Matt Jones, who's been at the heart of building and demonstrating the dashboard as it's gone through its initial life cycle. Just before I do, a couple of context points really, I guess. Obviously the ambition is to ensure that this becomes a really significant repository of information, and the data is simply the input to get you to that point. And for it to achieve that, it clearly needs to be as complete as possible. It's been a huge effort on the part of the participating organisations in BHR to get us to this point, and you'll be able to see how we're able to look at the entirety of the BHR place workforce, but also still look at individual organisations. So it's really helpful to be able to do both. In terms of completeness, we have made a good start on the primary care workforce element, but to be frank, there is still more to do to gather information in that space and ensure that it is a completer view as possible. The other thing to say is at the moment, the insights you'll see represent a point in time, and it's quite clear for a tool like this that what is needed is regular refreshes. Of course, the workforce makeup and information changes, and the ambition going forward will of course be to get trend information, because that's going to be so vital to really understanding some of the key strategic workforce challenges. But looking at what we can do now, as Simon has said, I think it already puts BHR in a position where it can clearly see its major workforce gaps. With the imperative that's been discussed earlier on about enabling local employment, we can see where your workforce lives, and all of this, I'm confident, can inform decision making on recruitment and retention, and provide us with some clear metrics to see actually we may have the ambition, but are we actually making progress? And as we get information refreshes, that will be enabled. As just been discussed, but across all of health and social care, it gives us huge insight into the equality and diversity agenda. And the same conditions apply. If we set ourselves some targets, it ought to be very straightforward then to measure progress against those. And at the more operational level, for each workforce group, we can look at things like sickness levels, where is a workforce perhaps under even more stress than has been commonplace recently, as is evidenced by sickness levels, and even the shape of the workforce in terms of age. In another situation, by doing this sort of work, we identified a really critically important frontline team that had 80% of its workforce within 5 or 6 years of retirement. And without this analysis, I don't think it was quite understood, and it did give the opportunity to actually proactively start to manage that. I think the final couple of comments from me is, whatever the shortcomings, and we will never have perfect data, what this provides is a single version of the truth that people get used to and can use as a common tool set for decision making. And quickly, I hope, moves people into the conversation about what we don't know to conversations about so what's. We know enough to actually enable decision making. And again, from a strategic point of view, I think it has all the potential to be a single data repository, so that from a point of view of supplying all the information requests that need to flow up and down the system, we can help BHR be very much more efficient at that, and prevent the frustration of what feels like repetitive data requests, because we already hold it and it's just another analysis we need to run. And then the final thing to pick up on Simon's point is, throughout the whole life cycle, we've been extremely conscious of information governance around this. This is sensitive data. It is vital that we are wholly compliant, and that has been absolutely at the forefront of our thinking. So although we are able to provide deep insight, we're able to do so in a way that is wholly compliant from an information governance point of view. So those were just the overall context points I was keen to make. And then Matt, deep breath, and over to you to take us through the model.
Thanks, Martin, and thanks to the Academy for the opportunity to present today. I've got a couple of slides to run through, if that's okay. The first you'll see is about benefits and capabilities, and the second picks up on some of those information governance points that Simon and Martin have alluded to before I get to the full demo. So I'll start with a big question. What is it? So it's an online interactive dashboard that covers health and care. And to pick up one of the comments that's been made, that is adults and children's care across the local authorities across BHR. What are the benefits that it brings? So as other speakers have mentioned, it is a single consolidated view of workforce across BHR in an easy to understand visual summary. There is a range of charts, dashboards that all exist at the moment, and I'll talk you through those. I guess it's important to say that you should kind of consider this as an appetizer, though. This is not the final suite of analysis. This is a kind of taster of the sorts of things that we could do. Technically, so the back end is using Microsoft Power BI, which I know some of you will use in day-to-day reporting. The benefit of that for us is it gives us an automated process, so we can drop new data sets in and update the whole dashboards very quickly and easily. The benefits strategically, I think everyone has alluded to the kind of people planning and the workforce strategy, but also there are other fringe benefits such as data quality improvement. So the standardization of data to allow us to compare local authority data, let's say with mental health and acute data, has meant that we've had to build a data model in the back end that allows us to do that, and that's highlighted some data quality improvement issues. And as Martin and others have mentioned, that reduction in duplication is a benefit to all, I think. So what's in there, the capabilities at the moment? So we've got staff numbers, FTEs and headcounts. We've got sickness and absence. We've got recruitment that includes turnover, vacancy rates and agency spend. There are some personal details around age, gender and ethnicity. Then we've brought in some public data sets to look at benchmarking and pipeline analysis. And finally, in the existing data, we've got some mapping, and I'll show you some of that in the early part of the demo. That is obviously the current situation. I guarantee by the end of this session that list will have grown in terms of aspirations and things people would like to see, and that's exactly what we want to hear about. So the next steps, so what in addition to those different data sets, the next steps, as Martin mentioned, is to have a additional quarterly or 6 monthly refresh of this that allows us to do some trends. So the next slide is here because when we've done demo in the past, people have rightfully asked us about IG and who can access what. Recognising there is some sensitive information in here, we are very keen. The kind of first rule of this whole project has been to make sure that IG has been locked down as much and as appropriately as possible, and that agreement has been reached across all organisations. So to keep things simple, we've got 3 types of users. So there are system users, organisation users, and all access users. So the system users is a small group of named individuals, and that's managed by a kind of a steering group from the Academy. They have access to data at all levels, so there's no small number suppression. And the purpose of that is to allow system-wide workforce planning. So they will have a high-level strategic view, but a detailed view as well. And again, that is all encoded in the IG agreements that all the organisations have signed up to and agreed. Second, there are a group of organisational users, again, named users within each organisation who have access to all of their own data. So again, no small number suppression, they can see everything that they provide. That allows them to do organisational workforce planning, and you can already imagine a range of dashboards that each organisation may want to see and a detailed view of their own workforce. Then finally, there's an all access user group, which is people from across all Academy organisations. This is high level data. So this is it doesn't allow access to identifiable data such as gender, ethnicity, etc. There are no filters, so you can't de-identify or re-identify rather people. No download functionality, that sort of stuff. So very much kind of buttoned down version of the data set. The aim is to allow information, kind of a high level strategic view, but importantly, this doesn't give any more detail than NHS Digital and Skills for Care public sources. So hopefully that's headed off some of the questions about IG. I will now share my screen and skip across to the demo. So this is the landing page. We can see that there are just over 14,000 FTEs across the health and care workforce in BHR. We've got a number of analysis on this landing page. What is that? Looking at staff groups, so nurses, doctors, social care staff, etc. Ethnicity, so the size of each of these boxes is the size of that particular workforce, and an age and gender analysis here, women here and men over here. Down the bottom right, we've got some summary analysis in terms of there are nearly 2,000 vacant FTE posts across the area, which is a vacancy rate of about 12%. An agency spend across all organisations that we've got data for so far of over £93 million in a year. A participation rate, so that is the difference between FTEs and headcounts, so essentially a kind of metric of part-time working, of 89%. And again, each of these has a kind of information bit, so we're not expecting everybody to understand these from the get-go, but hopefully with a bit of familiarity that will start to make sense. A sickness rate, so 5% of time lost to sickness, and a turnover rate of all organisations of 10%. And we'll dig into each of these as part of the demo. So I mentioned that we have postcode data. So what we do with that is we convert that to an area called a lower super output area, which is a technical name for essentially a population of about 2,000 people. So we don't have any postcode data in here. We don't have any detail like that. That's all been masked in the back end. And what this allows us to do is to map where the BHR workforce, the health and care workforce, live. And going back to previous comments from Joe onwards, that really helps us to understand that local community employment and kind of plans in that area. There's all sorts of ways of filtering this. I'm actually not going to do that as part of the demo because the maps go a bit slow because we're on Teams, but hopefully you can imagine all sorts of different ways that we could use this, and hopefully all sorts of different analysis. The next analysis is looking at staff groups, salaries and sectors. And again, this is partially to show the sorts of functionality that we can do. So if I was to, I can click on here and everything else is kind of lined up. So this, when we've had some questions about why we were asking for line by line personal data and not aggregate workforce data, it's so we have the ability to do this sort of analysis. So for example, if we want to look at nurses and health visitors in more detail, we can drill down and that gives us the breakout and everything else updates. So again, hopefully you can start to see some sort of analysis that might be interesting to your organisation or to the system. Looking at age and gender, so you'll remember this from the front page. Again, we can use this to filter what that looks like for different organisation types, or all sorts of different things. One of the questions that may come to mind at picking up on others' contributions is what the retirement picture looks like. So we provided a separate retirement analysis. So this is only looking at staff 55 years and over, age 55 and over. And again, we can start to look at what that looks like in a mental health setting, in an acute setting, in local authority, and primary care. And again, you can start to see that actually really helps to identify particularly which workforce groups, so that's nurses and health visitors or doctors or central functions, where there may be a retirement risk in the imminent future. Looking at gender and ethnicity and picking up on some of the comments that Gail helpfully made earlier, we've got all sorts of different ways of cutting this data. So for example, if I wanted to look at, this is the white population, we can see the kind of salary profile. We can see that is different for the Asian population, and again, very different for the black population. So there's all sorts of different ways of cutting this data. And again, as I said earlier, this isn't meant to be a final set of analysis, but hopefully you can start to see how using really granular data in a sophisticated system like this can really help inform decisions. Looking at sickness, so these blue bars are full-time equivalents by work areas. So you've got maternity and corporate, etc., etc. And the orange blobs are the sickness rates. So immediately you can see that there are two outliers. So this is outpatients, and there's 12.5% time lost to sickness in that team. And again, pathology. So there's all sorts of ways, again, I can imagine this being used, all sorts of ways that we could filter on it. So we could just look at the local authority, the acute teams rather, or the local authority teams. Again, I'm sure there's all sorts of different ways that can be used. Turnover rates, similarly, blue bars are FTEs, but this time the orange blobs are the turnover rates in the last 12 months. So here we can see mental health turnover rate of over 40%, general medicine 35%, and what else have we got here? Clinical support, over a quarter of staff turnover in the last 12 months. Again, helps to identify which are the real problem areas, and again by size, so we know which are the big areas and which are the big problems, and therefore again helps us identify strategies and put plans in place. Looking at vacancy rates, again we've got the FTE vacancies and some numbers of vacancy rates. So here, child and adolescent psychiatry, 32% of the full-time equivalent posts are vacant. We've got a spend of 93 million, as we said, on agency, and again we can break that down and look where that is. So for example, if we look at the acute, we can see that's 862 vacancy FTEs and a cost of £44 million to fill those gaps. So again, I'm sure you can all think of ways of analysing this slightly differently for your either organisations or across the system. So talking to the Academy team, one of the things that was clear at the outset is that AHPs represent a challenge and an opportunity. And I think this is the first time that we're aware that a single population of AHPs has been analysed across the system. And that goes for any workforce group. We can now pull together, we can kind of cut the data in a different way and say, okay, let's look at all pharmacists, all AHPs, wherever they work, whoever their employer is. And again, we can look at that in terms of work areas, role types. These are sickness and absence data around by salary, but there's all sorts of other ways of doing it. So we've got 1,000 AHPs and a participation rate of 88%, but I'm sure again you can all think of interesting ways of directions of taking this analysis. Switching from the data that the organisations with BHR have shared, we've also brought in some public data. So this is a 5-year future workforce risk projection for BHR. There is a helpful information box up here. So it's essentially the difference between the demand for staff over 5 years and the supply of staff over 5 years. And they've been graded in terms of risk. So the red is the demand is 25% more, the demand for staff is 25% more than the projected supply. The demand comes from population weighted ONS and HES data, and the supply comes from HE forecasts. Again, we can talk through the methodology of this perhaps in another session, but hopefully that's enough for the purposes of a demonstration. Oops, get rid of that. But we can start to see actually which workforce groups are in particular supply and their sizes. So this is support staff. Again, we can start to dig into each of these. Nursing and health visitors, so that health visitors and district nurses are two of the key challenged areas across the whole of BHR. Looking at a slightly different data set, we've now got some primary care benchmarking. So this was to understand, are the staffing levels within BHR, how do they compare to the rest of the country? So actually, let's take the rest of the city. So if we look at London, we can see that overall staffing levels, so this is FTEs per weighted population. We can see that the 3 boroughs across BHR are understaffed compared, or certainly have lower staff levels compared to the rest of the city. If we look at just GPs, so that updates all the other charts, we can see that Redbridge is a little bit higher, but Havering and Barking and Dagenham certainly look like they have much lower levels of GP staffing than the other boroughs across the city. If we couple that back with the retirement analysis, again, we could do a deep dive into each of these. You start to see there's some powerful analysis that comes from this. We've got a similar benchmarking approach across acute settings. So again, if we look at London, BHR UT looks towards the lower end in terms of the staff numbers per, this is by 10,000 episodes in terms of standardizing it. But actually, if we look at it by large acute, then arguably it's kind of on trend, well, on the average for comparable trusts. But again, we could look into what does that look like for doctors, or what does that look like for other workforce groups. Again, the kind of opportunities for analysis here are manifold. There is actually a benchmarking for local authority. We're not going to show that today just because the data isn't granular enough to give us any useful insights, but I'll just say local authorities are definitely not being left out. So finally, well, hopefully that gives you a good kind of, it's a bit of a whistle-stop tour, but hopefully that gives you a good introduction into the dashboard. I hope it kind of sets the scene of the sorts of analysis you could do and the sorts of work that this could generate. I'm going to finish up on a note on data collection and picking up on something that Martin said. So there are 116 primary care practices across BHR. Currently, we have 18 returns, which is just over 15%. So I'm going to finish with a call for any primary care colleagues on this call. Whether if you're interested in providing data, then please get in touch with the Academy, and we can add your data and bring you into the data set too. I will stop there and hand back to Ali, I think.
Thank you, Matt. It's been interesting because it's generated, we've got some comments that have come in. I am going to use, we've got half an hour with which to, well, probably 20 minutes with which to open this up to the audience, because I think the value of what our session aims to do today is to really, you know, this is the first phase of the data management dashboard development was about proof of concept. So this has never been done before. So we are learning by doing, which is the principles behind the Academy. And in shaping our future workforce, we'd really value your comments. So Dr. John, you kindly have volunteered a question. I wonder if you would mind contributing. I'm quite happy to read it out, but and I've sort of answered your query, but I think it would be really valuable from a primary care perspective for just some feedback in terms of the insights that this can offer and how we can help shape that to offer that out to the wider workforce planning capabilities to really increase and scale up the support we can offer for primary care. In your question, you have asked the question, can I ask have we been using some of our private providers to help with the NHS backlog work? At the moment, the data that's in the tool is about our employed workforce. This is a first cut. It's in its early evolution. As we get more confident with it about what it tells us and how we can shape that, definitely we need to shape the future capabilities and look at our wider impact on workforce development. But I'm just going to ask you just whether or not you would mind offering some comment.
Thank you, Alison. So yes, it's really good stuff, and certainly there's lots of learning. I think one thing that we learned through the pandemic is we started to look at the workforce in its entirety across the system, and hence why it became a huge exercise for the NHS. We started looking at the private providers, how many staff they were, what staff they had, to support the kind of NHS. So in that time of a pandemic, it became quite an important part. And we do traditionally, and like social care, I think we tend to go out to agencies and wider when we need backlog, like most of the organisations here. So I think you answered it, Alison, about the kind of wider elements in terms of, you know, will we be in a position to start taking note of some of those kind of other staff in those other private, for example, private hospitals, which we use quite a bit. Now, the problem with that is sometimes it's the same staff, so you may not get huge amounts, but there is something I just think that might be challenged. But in terms of primary care, there are some of our federation colleagues are in this, so that the federations do hold a lot of information for our practices. We've been building this tool and with our colleagues in CPEN as well, where they've been building. There is a lot of rich data, and certainly for example, our organisations like KEG, which is our kind of a lot of our information BI4 for particularly practice data and some of the CCG commissioning data, they hold a lot of this data. I definitely think there is scope if primary care did provide, because we do have a lot of I would say cross roles with our primary care networks. So paramedics, pharmacists, and they tend to be ex-hospital and trust NHS trust staff, as well as things. So there is a huge scoping, I think, Alison, to answer your question, that if primary care is very much involved. But I think it's really important. We shouldn't underestimate the community and the primary care. We hold a lot of staff, and I think any academy that doesn't really involve primary care in its fullest, I think will be probably it will be slightly short-sighted, because I think a lot of our solutions are in the community in terms of supporting hospitals and trusts within the thing, which I know obviously your aspiration is to get that all involved. So certainly I think it's in primary care's defences, we get asked about our returns of staff pretty much every other week from different organisations. So I suspect that you're finding that we're having email fatigue at the moment. So I'm sure they will get involved, but it is simply because it's been an everlasting, and as with all hospitals, return, and it gets boring. But yeah, and it's great work. Thank you, Alison.
Thank you, Dr. John. Barbara, from a social care perspective, we've been working very hard. You've raised a couple of questions here about the level of roles, so I just wondered whether or not you would want to just contribute to the insights and the good work that we've done, but actually some of the breadth of what else we can do.
Yeah, of course, thank you. So we're looking to really bring social care front and centre with NHS, because the social care is as important as NHS, certainly from my perspective, but perhaps I would say that as a Director of Adult Social Care. My comments particularly in terms of the dashboard, it looks really good, but sort of badging up social care as one group, if you like, kind of doesn't capture that granularity of roles. And that will be important for us to understand, both in terms of workforce availability and capacity, but also how we, as social care, can really get involved with the academy much more so than we have to date, from the perspective of career pathways, apprenticeships. Someone might start their role in a care home, for example, or with a home care agency, and is able to do an apprenticeship to move into a clinical role or a professional role, such as a social work degree or OT, that kind of thing. And how we get that, we really bring in the breadth of sort of experience, certainly in our social care provider market, around having that pathway into other things and keeping that workforce, if you like, fresh. I think John Timms put in the comments that the vacancy, the turnover rate rather, in home care is more like 30%. So it's just wanting to kind of keep us up there, and to be seen as important as the NHS, because we're so interdependent on each other, that if one falls over, that has a massive knock-on effect on the other.
Thank you, Barbara. And I would like to just reflect that actually, whilst we've looked at adult social services, that within the data we have the complete data. So this is about supporting children and young people. It's about supporting, the future supply chain of shortages of workforce, particularly around AHPs, and thinking about what our future workforce needs to look like in the future, because the current workforce probably isn't the right shape, and we need to really ensure that we've got new roles with new career paths and new career development that can actually really support out of hospital care and really provide the care and the care that's asked for by our population, whether that's their understanding of whether it's primary care, secondary care or social care. They just want care, and we need to make sure we've got the right workforce with the right skill mix, with the right analysis to understand our needs, demographics, etc. So yeah. I just wanted to reflect, this is a bit of a call for action from primary care. As you can see, we've got all of the other data from all three local authorities, from NELFT and from BHR-UT. Everybody has worked to the same level of granular detail on the specification. So we're comparing apples with apples. And that means that actually for the first time, we've got a whole picture. But we can't do that without more representation from our primary care colleagues. So I hope that the information in the data here is helpful. We recognise that you get asked time and time again for repeated requests. What we aim to do once you've got your data in is to systematise this so that actually the data within the academy becomes the primary repository that informs upstream data requests, which should reduce duplication. So we are in the early phases of development. I think the other aspirations we can think of in terms of what this tool can offer, if we were able to plug in the JSNA, if we were able to plug in employment levels, if we were able to employ and plug in our agency supply chain, this would give us even more capabilities. What we've got is the starting point of a very strong opportunity to really evidence-base our future decision making. And I hope that that's the USP, if you like, of the excellent work of the partnership. We could not have done this in isolation. This has been such an endorsement of collaboration because all of the partners have bought in, signed up to, committed and made it happen within very tight timescales. This tool has been developed in the space of 6 months, and the capabilities of what it offers to develop career pathways and meaningful jobs in health and social care to improve health and well-being outcomes is absolutely cutting edge. So congratulations, BHR. This is no mean feat, and you should be very proud of yourselves. Martin, just as a final comment from you as the developer of the model, hearing some of the feedback, is there anything from your perspective that you'd like us as a system to think about?
Well, I think we always knew we'd need to be on a development journey with you. So this is about continuing to share the current capability, seeing where there are shortfalls. So, you know, picked up obviously the commentary on the whole social care workforce, and we've talked about primary care, seen the commentary on non-NHS, non-local authority workforce. I think from our point of view, it's about a constant dialogue of what are the decisions people need to take, what information does that mean they need, and how can we help? You know, and essentially you're just constantly iterating the tool so that it meets those requirements. I think the other thing we all know is we're going to get different asks from the centre. So developing a single repository that makes everybody's life simpler to be able to do that, and that a lot more people have sight of the same information, because otherwise so much time is wasted translating between one and another. Whereas if everybody's got access to a single source of information, I think that'll be enormously helpful. But as I said, Ali, I think the main point from us is the one you made, which is, you know, this is proof of concept. I believe the concept is proven, and it's just about then capturing everybody's comments so we can improve it.
Thank you, Martin. On that note, we're going to ask the audience. So we've established a poll. We're going to invite you to participate so that we can gather some feedback in terms of the contributions from our speakers today and how this will help shape the ambitions to really strengthen our workforce planning capabilities. So I'm going to hand over to Ben, who's going to run the poll, and you know, precious to the technology, we are hopeful that you'll be able to input the data that we need so that we can actually collect some of this information. It's a bit technology dependent, but so Ben, over to you.
You open up the chat sidebar. Barbara's just made a comment, but just above Barbara's comment is the poll. You just click on the poll, start Polly, and you have 2 questions. It will take less than a minute to answer them. If everyone could just click on to start Polly. Right, thank you. That's 4 completions. Thank you.
Ben, whilst you're waiting, can you just read out the questions?
First question is, I am confident that my organisation will be able to use the data from the dashboard to strengthen our workforce plan and development needs. And the second question is, if I can get to it, I need to answer that myself, actually. I'll agree with that. The next question is, I am confident describing how the BHR Academy will help improve recruitment and retention and grow our own expertise.
So are we getting the responses through?
We have 36 completions. We are now up to 40 completions.
And is that beginning to give us any indicators?
Would you like me to click on to view results and have a look?
Yes, let's have a look.
So for the first question, I am confident that my organisation will be able to use the data from the dashboard to strengthen our workforce plan and development needs. 28% strongly agree. And for the second question, and then we have 53% agree, 4% disagree, 2% strongly disagree, and 12% are neutral. think the neutral response might be to do with questions that haven't been answered yet. So let's look at the next one. I am confident describing how the BHR Academy will help improve recruitment and retention and grow our own expertise. 22% strongly agree, 60% agree, 8% disagree, 0% strongly disagree, so nobody, and neutral, 10% are neutral.
So in terms of the strongly agree and agree, we've got fairly strong endorsement of the direction of travel, that seems to indicate to me.
I think so, yeah. I think with the neutral responses, that they're waiting on some questions to be answered, so we'll get some FAQs out as soon as possible.
Okay, so I'm just going to draw in Simon again, just as a final roundup of this section. From your perspective as an HRD and the ambition, what in its most simplest terms is this tool going to really make a change, make a difference? What difference is this going to make to your day job?
The critical thing for me is it will allow an efficiency of direction. So rather than me guessing on a fragment of the workforce what I think is important and where I think actions will make the most impact, I can actually go back and say to my colleagues or my executive team, and in discussion with wider system colleagues, I know that this is important because this is what the data is saying, and I know that this data is correct because it is a whole system approach, and we therefore avoid the interminable, is the data up to scratch or not? So it is that robust evidence base that allows an efficiency of decision making.
Thank you, Simon. So we've had the poll. We will be using that information as sort of some of the evaluation. So if you're still thinking about contributing to that, please continue to do so. Thank you to Martin at Attain and your team. I know it's been a really interesting journey over the last 6 months, but I hope what this helps us shape and move forward with is just the excellent opportunity that this really allows to underpin, our supply chain, our ability to really think through where our most impactful time can be spent to really think through our career development, but also to help. I know we've got in the audience today some of our education partners. What we really want is our education partners to really hear the sort of skill sets, the multidisciplinary team skill mixes that we need to create new roles for, and really harmonise that educational pipeline so that actually we can work in partnership with you to strengthen the ambition for people to come into career pathways that really harmonise and help shape the future for our workforce supply chain. Joe, I'm just going to sort of put you on the spot, sorry, just to reflect. So we're sort of a midpoint really through our innovation here that we're sharing for the first time to a much larger audience. From your perspective, in terms of the offer underpinning the Academy, it would be really good to help hear from your perspective the insights. This is very new and you've helped us with the journey, but what does it offer from the Academy's perspective?
Yeah, thanks, Ali. And I guess I would start by reflecting back on one of Simon's comments just there, really, which is about this kind of sense of one truth, one whole data set that we all can share openly, transparently, honestly. And I remember as an early days Ned asking questions about, how does our workforce planning come together? How do we anticipate real pinch points in our workforce and our needs? And how do we evolve if that need's not immediately fulfillable into innovation and creativity to sort of generate new roles, new disciplines, new ways of working in our social care and our healthcare workforce to overcome some of those barriers. I would also say I left school at 16. I was an apprentice. I benefited from further education in East Ham College, in Holloway College, and so my own journey to become chair of this trust would not have been possible had it not been for innovative and creative and opportunities afforded to me that I would like to see replicated now through our academy into our own communities. I'm a huge believer that the people are out there to fulfil all the needs we've got, and we need to reach out to them. You know, I liked Catherine's point about we need to market ourselves much, much better. We've got so much to offer, and we don't shout enough about a lot of that. You know, so very much supportive of Jagan's contribution, because we know that Jagan can help persuade GPs to participate in this, so that we can take that 15% up to 100%, hopefully, and really support primary care as well. And Barbara's comments from social care, you know, very, very relevant that we think about social care in all of its complexities and all of its disciplines, and that we recognise the parity of esteem that social workers and social care demands alongside healthcare. So I think it's been a really useful session for me to listen in on. I feel privileged to be offered to comment back on it thus far. And I'm hugely looking forward to the second part when we get into some other deeper aspects of it. So it's been great so far. Thank you.
Thank you, Joe. So that sort of sets the scene in terms of the infrastructure. And the second part of our launch event this afternoon aims to demonstrate how our further partnerships with our wider partners in the training hub and through some of the work of the London Healthcare Partnership can really support the journey of integration. So, you know, integration is never going to be more critical than it will be in the future years to come. And our relationship and operational partnerships with the training hub and with organisations like Care City are absolutely critical to our ability to really engage and systematise this huge vehicle that we're trying to support career development with. So I'm going to hand over now to Dr. Jyoti Sood and to Paul Olatan, who are going to help take us through the journey of what integration will look like and how some of the care pathways we're approaching is going to develop. So over to you, Paul.
Thank you very much, Ali. Right, so you'll notice I'm here alone. Unfortunately, Dr. Jyoti Sood has been called away to clinic, so you've got me. So hopefully that doesn't disappoint. Do we have some slides?
Yes, they're all on the screen for you, Paul.
Oh, all right, there you go. Okay, thank you very much. I'm really pleased to be here today. Thank you for inviting me. Really excited about being invited by the Academy to support a couple of the work streams through their work programme. My name is Paul Olatan and I'm the programme lead for the BHR CEPN Training Hub, Community Education Provider Network. And we are, just for context, we are funded primarily by Health Education England, as well as some additional work streams through NHS England. And there are CEPN's training hubs in every CCG area. So for our purposes, we work very closely with our colleagues across North East London to bring together a focus on priorities, workforce priorities at the North East London level, working with the ICS, to focus on areas such as retention, new ways of working, well-being, inclusion, diversity, and we've heard lots around bits of work and work streams such as that. Bringing it closer to home, we support the local system, cross-sector working, creating digital spaces, developing a very comprehensive and growing clinical webinar series, as well as bringing focus to our education approach and particularly the faculty. Our core reason for being is to support, put it under the banner of supporting the development and emergence of integrated care. And our direct focus on that in the local system is to support the establishment and development of primary care networks. We see, along with other system partners, primary care networks as being the primary locus of integrated care. And so our role as a workforce function is to identify and deliver opportunities for the development of collaborative working, multidisciplinary working, interprofessional working. And so we have a number of activities, some examples on the screen, around supporting and developing leadership, both clinical and managerial, developing opportunities to support newly qualified people just coming into the system, as well as bringing a clear and keen focus to supporting what are essentially new roles within primary care. For those not directly familiar with primary care and primary care networks, ARRS roles are additional roles reimbursed, where the funding is reimbursed to primary care to attract and recruit new professions into the delivery of the primary care space, and with a real focus on allied health professionals. And across the board, there are around 14 or 15 allied health professional roles under that banner. For the purposes of primary care networks, there are 4 key AHP roles: physiotherapists, occupational therapists, dietitians, and paramedics. So a big part of our role is to support those professions really find their place and their space within the primary care arena, and feel that this is a place that they want to stay, they want to develop, they want to grow, and they want to make that contribution. And then for the focus of the conversation we're here to have today, we've been invited by the Academy to lead and develop 2 particular, I think, defining work streams for the system, for the Academy and for the system, and they really do talk to some of the comments that have already been popping up in the chat function. So in the first instance, the allied health professional pipeline across the system and beyond the AHP professions, the key challenges for BHR and the workforce are about attracting people to work here, recruiting them, developing them, and supporting them to retain and stay and grow and develop. And so we want to bring a focus to that ambition and those activities, and then developing that into an additional but very much related activity work stream around the support of the musculoskeletal care pathway steering group and the system-wide long-term conditions transformation board, to bring a real focus to the improvement of the MSK care pathway, so improving access, referral pathways, the delivery of care, but ultimately improving the experience of care that people in our communities have. So if I could have the next slide, please. Thank you. So just very briefly, to almost kind of just stop on our or just touch on our theory of change, if you like, which is very much as we are core funded by Health Education England, that we really want to see the establishment of education as the key driver for change and transformation in the system. So our approach, and we've developed this career development model to support the whole range of professions primarily in primary care networks and general practice, but extending and expanding out across the system. So a real focus on identifying who our educators are, bringing them together, supporting them, developing them, sometimes recruiting them, but doing that across all of our professions, so we can then start to bring them into a multidisciplinary environment, a multidisciplinary faculty. We very much see the role that if we're interested in supporting interprofessional conversations and relations and interactions, in the workforce, then we need to underpin that with the conversations and directions and input that our faculty, our educators are able to enjoy and deliver and bring into the system. And then moving on to thinking about the places and the spaces that our activities occupy. What's the quality of provision? What's the quality of provision that our system needs and requires? How do we engage our training providers? And what role do apprenticeships play in that that journey from entry roles, first time practicing in our system, and seeing and setting out a clear career progression to give people confidence that in BHR they can establish their career and have a future, very productive and contributing future, and then thinking about opportunities such as kickstarts to really start to focus and target our efforts and energies collectively on supporting local people, and in particular supporting local young people, as Catherine has highlighted, to see that health and care, and particularly health and care in BHR, offers a route to employment and career development for them. And then thinking about the people we actually engage, the people we support. It's one thing to provide opportunities for them to do their current role better, but how do we support them to lay the foundations for collaboration, which we see as the bedrock of integration? So to create and provide opportunities for them to come together, but whether virtually or in person, around peer support sessions, around collaborative learning, developing communities of practice, interprofessional group activities, to really start to relate to each other, to develop that common understanding, that respect, to see themselves as part of a greater whole system, a greater whole workforce, rather than individual siloed, fragmented parts of the system. Because ultimately the role that we want to deliver collectively is an improvement in the experience of care, but for us, not just an improvement in the experience of care for those accessing care, but importantly for those that we support and our system employs to deliver care, that they actually feel valued and that they feel that they are providing a valuable resource to our local communities, because that, we feel, is the root of the retention ambitions that we all have. Can I have the next slide, please? So, by way of trying to bring some kind of life to this this journey, I'd like to introduce you to Katie Francis. Now, Katie is on the call, so hopefully, Katie, I bring justice to your pathway and your journey. Katie has been an occupational therapist for 25 years. She's always had a passion for people, always seen a public sector ethos as being her reason for being. So she's born and bred in London. She moved to Liverpool to study an undergrad degree in sociology, and upon returning, she felt, a real desire to want to work in the public sector. Her first thought, consider social work, and I suppose it's a point of consideration for all of us when we're thinking about how to attract and develop career pipelines and attract professions into our system, to think about it in the round, to think about it in that systemic way, because at that time the brand of social work was very low. It castigated and vilified in the media, a sense amongst communities that social workers are just there to take your kids away. And unfortunately, fortunately for us, but unfortunately at the time, that image put Katie off of social work. So she thought, okay, well, what about primary care teaching? So she was fortunate to be able to spend some time in some primary schools, spend some time with some teachers, listening to them. And again, that was at the time, very demoralised workforce, very demoralised profession. And again, Katie was put off of pursuing a career in teaching. But then she happened to stumble across this thing called occupational therapy, and it really piqued her interest, because what she found was a profession and an activity that was really creative, utilised arts and crafts, and innovations to support vulnerable people and to support people who needed care and support. So she undertook a second undergraduate degree and graduated as an occupational therapist, and brought those passions of arts and creativity to support people with mental health concerns. And then, as happened with a lot of our public sector professions at the time, the space for that creativity and innovation started to diminish, and Katie found herself becoming more of a case manager than a case worker, and her and her colleagues were managing resources rather than interacting directly with patients and service users. And this became a bit of a challenge, and she started doubting whether or not the profession was for her. But then she remembered that it's all about people, her passion for people, and she refocused, redirected her energies and passions to supporting people to recognise the value of occupational therapy, and hope that they themselves could see it as a career for them. So she took up a secondment position at the Northeast London level to focus on the use of apprenticeships to develop pathways. She took on interim clinical leadership roles within NELFT, again focusing on apprenticeship pathways, to the point where she is currently in leadership roles at a Northeast London level, representing NELFT and others, and bringing together all the local authorities and the trusts and primary care to really start to understand how apprenticeships can, as I've said previously, set out a clear career development pathway to encourage people to have faith in the decision that allied health professional roles can actually deliver something productive for them. Can I have the next slide, please? Thank you. So final slide for me. So I landed on apprenticeships there, and all I want to do now is just looking forward, just give an example of how the local partnership comes together, works together on a range of different innovations, and just use this as an opportunity to talk very briefly about something called Enablement Champions, which we hope it's very aspirational at the moment, but we're doing lots of tangible work collectively. The CEPN, Care City, NELFT, and training providers are working together to develop this enablement champion role within the care sector, within the care home sector. And so what we can do with this is we can map out or visualize a career development pathway from an entry point as a care worker, undertake an apprenticeship, level 2 apprenticeship, and then moving on to become a senior care worker, lead practitioner, again through apprenticeship programs, and then working as a senior care worker within, senior support worker within a care home, working with allied health professionals who can go into care homes, enable and embolden the enablement champions to undertake those activities that would usually be delivered by an AHP, so that the allied health professional doesn't have to spend as much time in the care home. The capacity and competence of the care home workforce is enhanced, and then ultimately an enablement champion could make a decision that actually I quite like this idea of an AHP role. I've really kind of learned loads, and so to formalise those skills and competencies through either a 3-year degree or a 4-year apprenticeship pathway to become a fully qualified allied health professional. So that's the end of my slides. I think I'm going to hand over to, I'll hand back to Ali now.
Thank you, Paul, and a very inspiring case study on Katie's journey, and one that I believe truly reflects the ambition that we need to connect with in terms of developing that intrinsic motivation that underpins a lot of people's ambitions and why they come in to work in either health or social care settings. The passion that's generated to help people comes in many shapes and forms. We have the real opportunity of such a local wealth of local people who can really bring added value into our workforce. And if we can offer the right skills, training and capabilities, then the competencies that we can add are enabling, as Paul describes. I suppose one of the questions I would want is, how can we ensure that our future workforce continues to add social prescribing, and how can we ensure that actually the workforce has a capability of flexibility to work across our systems? So these excellent stories cannot be just individual aspects of somebody's career pathway. We need to achieve volume, and we need to achieve volume in our allied health professional skill mix, and start to think more broadly about what else can they do as we start to train them, so that we break out of the mould of specific care pathways and actually create much more broad skill mixes. In terms of how we're going to attract the workforce, that generates a very nice segue into the great work that's been done through our, sorry, John. Oh, now I seem to have added my slide. It really starts to focus on the career ambassadors role, and Care City is here with us today to talk through the excellent work they've done in North East London through the Health and Care Partnership, and is going to shape how we start to really think through what career ambassadors can help us with in terms of signposting people into meaningful careers in health or social care. So John, over to you.
Thanks, Ali. Great to be here. Fantastic presentations to listen to. My name is John Craig, Chief Executive of Care City. We are an innovation centre for healthy ageing and regeneration. We were co-founded by NELFT and the London Borough of Barking and Dagenham. We're now an independent community interest company. Our communities in East London, and our mission is a happier, healthier older age and for East Londoners. So in that context, we are extremely proud to be a partner to the Academy. Also, I was super excited by that dashboard. So amazing to see all that data about where staff live. You know, we could really use that data to make care and health one of the sectors that drives the regeneration of East London, and that's a big part of what gets Care City really excited. We work across research, innovation and workforce development. I'm just going to talk briefly about one of the things we're doing under the latter of those badges around supporting North East London's Health and Care Career Project, and we're really proud to do that. I think it's easy to think of Careers Project as some advertising in the labour market. I think it's a bigger deal than that, really. If you think about, in this part of London decades ago, people being socialised into jobs in, say, Fords in Dagenham, they were socialised into those jobs by friends, family, community, intermediary organisations that helped them find something to do in the world and something worth being. I think in this work, we're just trying in a really small way to rebuild some of those institutions that help people find their way in the world. And that's a bigger deal than advertising. And we're really, really proud to be part of it. I'm just going to say a little bit about what we're doing. And at the heart of it, as you say, Ali, is our work to recruit and support health and care ambassadors. So the aims of the work, where we're supporting North East London Health and Care Partnership, is about helping schools and young people on the one hand, and health and care employers on the other hand, to find themselves and hopefully to match around roles that really work for young people. So that's about building relationships with schools and employers, about providing information, and we've had a big focus on online information, and it's about providing people who can reassure and inspire young people around the whole range of opportunities and roles that are available across health and care. And at the heart of that is our work to recruit health and care ambassadors. And just to think a minute about what's going on when a young person meets an ambassador. You know, we've just looked through the data. We've got health and care challenges. We really want to attract these young people into health and care, and we want to give them the very best offer that we can. I mean, my personal experience of running those events and talking to young people locally around opportunities in health and care is, more often than not, they don't think they're worthy of working in the health and care system. It's precisely what Catherine Halford was talking about, that people assume they need a degree, or just they assume they need to be a different kind of person, that the only people working in the health and care system are doctors and nurses, and that's not them. So more often than not, as much as providing a really attractive vision of what health and care work could be like, it's also about providing a real vision and providing people with images and stories from people like them, that they can look at and think, yeah, that's a bit like me. I could be that. It is possible for me. And without that connection, it's really really easy for people to exclude themselves from some of the opportunities we've got to offer. You can, my colleague Rachel's just putting in the chat the link through to the website to go and watch all of the video content from these ambassadors. And if you're a educator out there right now, please, and you'd like one of these ambassadors to speak with your students, come to your school or college, please do get in touch with us. I promise it's a really powerful experience. Elijah there is a paramedic, and he just talks really authentically about how being a paramedic in the London Ambulance Service has helped him to become the kind of guy that he wants to be. It reflects his values of being respectful and helpful, but it's also helped him to live the life he wants to live, to make new friends and kind of find a new identity. Fahima is a manager of a home care service, so she talks really personally about her route into the care sector, based around being a family carer, caring for her dad, and recognizing skills and potential in herself that she didn't know she had, and sort of following that vocation into the care sector, and now being a manager of a care home. And it's stories like that that I think help to bring down the sort of headline perceptions that people have of health and care roles not being for them, to become stories to which they can relate, and where they can imagine themselves in the picture of the health system or the care system. And as I say, if you'd like one of those ambassadors to come and support the work that you're doing, please don't hesitate to get in touch. So how are we doing? Well, we've not long started this work. I think we've made a very decent start. We've first of all worked with the integrated care system to bring together a lot of partners around this work. We absolutely understand the sort of blizzard of different bits of information and range of people that young people or schools and colleges might feel that they need to speak to, and we want to make that as clear and as simple as possible. We've recruited 113 ambassadors, getting to be more all the time, and we've run 9 induction sessions since March, and it's been an absolute joy to meet those ambassadors. And of course, we really want people to volunteer to be ambassadors. We forget just how proud and happy people are to become these ambassadors. There's a huge discourse in our culture around giving back to one's community and opening up doors for others, and people love to play these ambassador roles. It gives them an outlet for their passion to help their community. So if you're a manager or a leader out there in health and care, this could be an opportunity that could help to be the making of one of your colleagues. So again, please do follow the links and get in touch. There's always space for more ambassadors, and we're looking for ambassadors of all kinds. We've got inspiring, heroic paramedics that some of my staff may possibly be in love with, but we also have IT managers and business administrators. Again, as Catherine was saying, it's about people understanding the full breadth of opportunities in health and care. I always think of those incredibly high-spec adverts for the army that click through all of the roles that you can play in the army, engineer, you name it. And we have to get the same story out there about health and care, and these ambassadors are one great way to do that. And we've now started, as I say, to deliver events through these ambassadors. We've really just started. We've reached 204 event attendees so far, but that's really accelerating now. We've got an exciting programme of events through and into the autumn. But as I say, we'd also be really happy to add to those events. So yeah, volunteer to be an ambassador. support the programme if you're a health and care leader, and draw on this resource if you're a school or a college, and let's help to really connect these inspiring examples to the next generation. Something important to add, because I'm not quite as young as I look, is that we're ensuring that we work with young people to design this work. It's sort of no good me sitting in a room saying, yeah, that sounds really cool, I think that'll really go with the kids. We need to know what's a respectful way to reach young people. What are the contexts in which young people feel safe talking about and thinking about their future and their aspirations that they might hold dear, but they might hold secret. And so we're going to be working on that with a young person's panel. We hope that will be a great leadership development opportunity for those young people, but it'll also help us to not mess up in trying to shape a programme that communicates effectively with young people. I think we've learned from all of the incredible work actually that's been done in East London around community engagement and vaccines, just how hard you need to work to get from talking loudly to really getting your message across effectively. And we want to learn from some of that by working not just for young people, but with young people. Here are some of the quotations from people we've worked with so far. As you can see, they're delighted. I won't read them to you. We're absolutely not saying that careers ambassadors are a magic bullet, but I think we can all appreciate, we can all think of the people who played those ambassadors' roles in our lives. It can make a real difference. It can spark that fire in someone, and we'd love to work with all and any of you on this call around this, and we're really grateful for the Academy's support in this. I won't take you through all of those goals and metrics. We feel like we've just got started on this. We've had a great start. We're, you know, as Paul said in his presentation, we're working with a huge range of partners that we couldn't do it without. But the point is to make all of that complexity simple for schools and colleges and young people. And as I say, just follow the links and get in touch if there's anything you'd like to contribute or ask from this programme. Oh, you're on mute, Ali.
Thank you, John. Always really inspiring to hear the great work of Care City, and so valuable in terms of signposting. I think your reflection on the way the Army promotes itself on the TV, if only the NHS and social care could pull an advert like that together, what a difference that would make to be attracting people into roles in social care. So I'm going to talk to Ben about that after this event and see if we can make something up that we can put on YouTube or something, because you're absolutely right. It is about connecting intrinsically with those motivators that really harnesses people's ambition. And to Catherine's point about some people think, oh, it's a hospital, I can't work in a hospital. You know, we need to break down those limiting beliefs really in terms of what career pathways look like. So great work, and thank you for all the contributions that you do. If there's anything else we can help in terms of kind of sharing, then please allow us to do so on our Twitter feed, which is really getting good momentum now. I'm going to take us through, we're doing really well for time. I'm really super impressed. So thank you to all our speakers, because the contributions, I thought, goodness, I'm not sure how I'm going to keep this to time. On the next section is just a little bit of horizon scanning. Alan Wishart was due to be with us as the HRD from BHR UT today. He was called away first thing this morning, which meant we actually had a bit of a gap in terms of what I would have asked him to really endorse from an HR perspective. Now my slide deck's just gone down, so bear with me while I reload it. But I wanted to sort of just walk you through the journey of all the great work that, you know, started many years ago in terms of the thinking about how to overcome workforce challenges, the great work that Joe has alluded to and Catherine has alluded to in terms of the journey and how much time it's taken us to get here. We don't have the luxury of time really in BHR. You know, we have a real challenging demographic in terms of our population base. We have a real issue around retention. We haven't really covered retention, but I mean, obviously that's the biggie that nobody's talking about in terms of people come and work with us, they get trained by us, and then they go into inner London because they can get the extra inner London weighting. So, you know, the retention aspect needs to be thought through once we understand our current state view, our future ambitions in terms of workforce modelling, and what that means for the future supply chain. Forgive me, I've had to juggle the slides while I was covering all that. But I just wanted to, I think one of the other small successes we need to really, BHR really needs to pat itself on the back for is, you know, the ambition championed through the Integrated Care Partnership Board, through our Integrated Care Executive Group, through the sponsorship of the Academy, through the SROs, through to our frontline teams who have worked tirelessly to get the data management dashboard over the line in 6 months. That is no mean feat. So now we have some of the tools and capabilities. We need to create the movement. We need to create a transformation revolution for workforce. And in terms of the how, I think we have the how now. I wrote this slide in about February or March. David Amos was with us. I'd like to just endorse and thank David. He wanted to be with us today. But I have to say, the journey that the partnership went through in 2020 in creating the business plan that underpinned the activity and the rollout and the launch in 2021 has been phenomenal. And it's that strength of collaboration and partnership working and commitment to the communities of East London and BHR in BHR is really shining through. And I would like to just share with you this strategic plan. So, you know, it was a relatively high level plan and an ambition, but I would say we are now walking the walk. So when I arrived in January, we had the plan signed off and approved by the boards, and we had the intent to mobilise. And the activity in the last 8 months has really shone through that that's exactly what we've done. So on our plan, we had an ambition to get ready, get the Academy ready to really be the ambassador, the enabler, the virtual enabler. We're not a thing yet. You know, this is a virtual anchor-based principle to grow our own. And in so doing, we've put infrastructure in 6 months that has enabled a much more granular level of our current state. Nobody else has got that. Nobody else in the country has got that. So well done, BHR. You've done an amazing job in the last 6 to 8 months. So it feels hard, but you're really walking the walk. We provided the Get Ready phase to establish the Academy's identity, brand, put some infrastructure in place that would really harmonise our data and make it much more meaningful to have a data-led, evidence-based approach. We've done that. We've walked the walk. We've said we'd do it, and we've done it. We're now launching. So actually, first phase 1 of implementation has been achieved. So congratulations. We now move into phase 2, which is we now have a clear national target to grow nurses. We have clear local targets, which means we must prioritise on AHPs. The future workforce needs to be different. It needs to be more blended. It needs to have a much more multidisciplinary team output. It needs to shape interprofessional roles. It needs to be entry level. We need to encourage workforce to come and work with us, even though their confidence on their level of education is low. We can help them with that. But we need to work as a system, having conversations that, if it means getting 80 or 100 people in a room to talk about a single group of workforce, that's what the Academy will do. Because it is these broad conversations and the sharing of experiences and the sharing of where each component fits into the overall ambition that we all hold and value, which is to improve the health and well-being of our communities. This is how the Academy can help and enable that. It's not here to do it. The system is here to do some of the delivery. But what I hope the Academy can do is really shine a light on the key gaps in children and young people services, in integrating the MSK pathway, in supporting primary care to really increase its capacity. We've shown through the pandemic how when we get a call to action, we can work as a whole system. And never more now, if we're moving into integrated care system working, is that ever important, because the journey towards one workforce is coming. And we will only achieve that by sustainability of our workforce, through the sustainability of our partnerships, and the ability to accept the evidence base that our dashboard can inform us with, and then overcome some of the challenges around improving the flexibility of our workforce in a more meaningful way. We understand that clinical supervision is a real gap in terms of rotating our staff. We understand that clinical placements and rotations don't work very well. And now is the time to work together as a system to say, okay, we accept that everybody plays their part, but rather than working in isolation or in silos, we need to come together and really harmonise the strength of our capabilities in each of our sectors, so that actually the people that come into our care and the workforce who provide the care have the right tools, education and skill set and competencies that allow them to stay with us rather than change and leave us. So phase 2 is on this plan. It is largely aspirational, but we do have a new approach to really think through. You know, the data has shown us that actually AHPs is our critical system need. And for our education providers, whilst we do desperately need more nurses and more clinical specialists, we do need to look at prevention and providing skill sets in workforce that is more junior, but can offer blended interprofessional solutions which take the demand of some of our clinical specialists. So it is about that robust sort of approach on supply and demand. And we hope to do a deep dive on the 18th of November into our AHP workforce. It's set in as a date, but we would very much welcome contributions from primary care, secondary care and social care to really help and shape our thinking in terms of what's our 3-year strategy to grow our own AHPs. We have to move now. We cannot wait another 3 or 4 years to talk about it. We have to commit to do, and that's what we hope the Academy can really enable. So in terms of our call to action, I am going to ask Jo and Maureen Warby as our representative from the Integrated Care Partnership to just say a few words in terms of everything that we've heard today and some of the content that sets the scene really from both a health and care and integrated partnership perspective. So Maureen, can we hand over to you and just ask you for your reflections?
Thank you, Alison. I mean, Joe knows I'll throw down a gauntlet in this bit, and so do most of you who know me. Because do you know what? Today has been inspirational in one level, in that we've now got a richness of data that we'd be stupid to ignore. You know, so we can move forward on one front, but I'm going to reflect some of what Barbara's been trying to put in the meeting chat. And none of you would expect me just to sit here, because I think to a certain extent today, we've come back, and Joe knows this is one of my challenges always, to the same issue of language and what we mean by what we're saying. And I think there are different parties in this meeting who have a different interpretation of what integrated care actually is. And integrated care isn't just about integrating the bits of the health service. And, you know, and I think reflecting what Barbara said earlier, if we're really going to move this agenda forward, we've got to integrate the social care. And what my challenge out today was, it's been brilliant today, it's been really inspiring, but it's been very health centric. And whilst it sort of says, oh, and our social care colleagues, and this is no disrespect to anybody, Alison, it's, you know, what do we need to do to get more in that agenda? I'm not saying, you know, so the challenge is back to my colleagues from the 3 boroughs. We've got to make sure we're at this table and we're part of this exciting development. It feels at the moment, and I think, you know, Barbara was right, we've got that detailed breakdown of professions in the data in health, but social care isn't broken down in that same manner. So that's for us to give you the data and to push you and to talk to Craig and Co at Care City about, actually it's not just about, you know, the paramedic, it's about the social worker, you know. So I know we had an example of somebody who didn't want to become a social worker, but we actually need them. So do you know what, as I say, I wouldn't be me if I didn't come back and throw down some sort of challenge, but I do want to acknowledge that this is so good, and we've come such a long way, and I think there's a basis there for us all to build on and come up with something extraordinary. So my thanks to all the contributors. Thank you, Alison. Over to you, Joe.
Thank you, Maureen. Joe.
Yeah, hi everyone, and Maureen, great to be, as it were, sharing the virtual stage with you. You know, through many years of our working together on the ICPB for BHR, we've had lots of, I think, shared aspirations. I was going to say, Maureen, we've been partners in Shine, and the Shine part is wanting our whole community to shine, and I think you've just reminded us more than adequately of the need that whole means health and social care. Whole means all of us together building an academy that serves all of our needs. And really want to just maybe reflect briefly on John and Care City's contribution. I can remember as 3 years chair of BHR UTN NELF, banging the drum about growing our own, and why were we not doing more in our communities to generate ambassadors that were sending the message out, and just how much we've got to offer so many people, whether they're young people or they're mature students or they're people with changing aspirations as their lives change and evolve. And Maureen has absolutely the well-being of our communities at heart. I hope I share that with her. And it's great news, John, to hear about those, you know, 200 ambassadors that you aspire to have out there, spreading the word and spreading the message. The data-rich, evidence-based system is key. It's key because it tells us exactly where the gaps are going to come, where our priorities are, and where we can train people with the confidence we can then gainfully employ them and feed them into long, sustainable and fulfilling careers. So I applaud everyone's efforts. I thank you, Alison, for your energy and contribution, particularly in latter times, to get us where we are today. And I'll finish on the note of an old PE teacher of mine. He used to say to me, Joe, you've got little legs, but I want you to run as fast as you possibly can and then accelerate. And I think that's what the Academy needs to do now. It's running pretty fast, but let's see how well we can accelerate. Thank you, Ali. It's been a pleasure to be part of it this afternoon.
Thank you, Joe, and thank you to all of our speakers today. I'm really grateful for the valuable contributions. We've actually finished ahead of time because actually I cut out the comfort break, so I'm sure everybody's now desperate to go off early. We will be uploading this presentation to YouTube. So many people who registered couldn't actually be in the room, but by registering, they will be sure to receive the recording, and we will continue to take Maureen's comments and our colleagues in social care to use the words and the contributions much more for our residents, and to make sure that our language accommodates the united approach that we are developing together. That I think what today has harmonised is actually we all want to do this, and we all want to do this for the well-being of our local communities. So thank you, everybody. I'm going to close now, and we will be in touch with you more. Please follow us on Twitter. And share with us your feedback. We'll be evaluating what you found useful, and we'll be continuing to shape the data management dashboard into as robust and evolutionary tool to really understand what our current workforce, whole system workforce, will look like in the future. So thank you very much, everybody, and take care.
Thank you, everyone.
Thank you. Bye. Thank you.